webinar today. Hopefully we can take your mind off that a little bit today. Bill Malm is going to be presenting. He heads up our charge integrity team here at Vitalware, and he's going to be hopefully giving you a strategic plan for updating your Chargemaster with all the year-end updates. As usual, everybody is on mute, but please submit questions to the Q&A panel, and if we have time at the end, Bill will do his best to try to answer those. But other than that, I'm going to hand it over to you, Bill.
Thanks, Dusty, and welcome to everybody today. Thanks for joining us. Today, we're just going to do strategic plan updates. And we start, as always, with a bit of a legal housework, which is that this presentation is for educational purposes. Management decisions should not be made from it, and that the American Medical Association has all copyrights for the CPT, and the American Hospital Association to the revenue codes that are included. Now that we're over that, I want to talk a bit about the agenda. We're going to review the steps, define who, what, where, when things have to happen, how to access source data for your updates, and then create a plan that could use your VitalCDM reports. And we're going to be showing some of the VitalCDM reports. Have that product. Master review. And it frequently does not include any maintenance concept, does not identify the key stakeholders or the roles and responsibilities. So these should be in your procedure. From a policy, which is like 50,000 feet, you want to get it down to 20,000 feet, which are your procedures. And what do you actually do to make that policy happen? So timelines, milestones, appropriate data sources that you're going to attach, a recommendation from clinical staff on yearly maintenance, and then the contact information for the DM personnel, because they're going to be asking questions. Job aids are right at the work level. Job aids take from the policy to the procedure, and then they write very specific requirements that you need to do. So, for example, step-by-step instruction from clinical leaders on how to review your charges. And this is important because most clinical people don't really understand a Chargemaster, CPT coding, whatever. They understand their system does something, but they need help. Specifics on how you're going to get this data, and then provide plain English definitions. So I go in sometimes and I see job aids that are written in revenue cycle terminology, which is of course completely unhelpful to the clinical staff. Provide timelines and checklists so they can make sure they're on track, and ensure that the stakeholders have guidance that they can follow and be successful. Finally, the job aids are prevalent in most areas of the facility as an adjunct to policy. You will find them very frequently, job aids in the nursing department, and then down to, what you need to do is start an IV and what those infection control things are. And so they specifically tell the individual performing the act exactly what to do. The other thing I always like to see is using your internal intranet as a tool. So a lot of times when you're working with Chargemasters, oh yeah, I sent an email, or I get it from here or from there. Make a site, a landing page for all things Chargemaster, your house policy and procedure, any checklists that you want, meeting times, dates, and locations on a calendar, times and milestones. Contact information is very important. And sometimes when I go and I look at the review articles and the review step information for people that have long left the hospital, they're not there anymore. So making sure they're right. And then the ability to set reminders and out so that you can get their calendar through, or iCalendar, or whatever you're using. And then folders by department. And this allows you as a Chargemaster person to put in all those policies, procedures, checklists, milestones, whatever it's going to be, reference material, into a folder so that the laboratory isn't through the whole folder and going through radiology and emergency and OR. It's right in the lab folder. And many people with lab, because it's so extensive, they go ahead and they make subfolders for path, chemistry, things like that. First of all, you have to decide what are your source authority resources, and clearly the 2021 OPP's rule is there. The addendum B, we also have recordings of this and reference documents. So if you go to the main landing page at vitalware.com, you'll see the 2021 CPT codes updates. It's a downloadable thing, and you can pass that out to the rest of your team members. So how do I put all this in place? The first thing we have to do is determine who, what, when, and why. And the first is who needs to be on the team, who to be the leader, who interact with, who do they report to. So kind of the personnel functions of this. Then the what is the mission? What's the objective? Are they defined? What data do you need? What do they each member perform? So don't ask emergency services to get you the 2021 3M downloads. That's when is an iffy topic, because it is January 1st, all these things have to be in, but some people like to start in September when many of these preliminary codes are published. And then starting earlier is good. When should it end? Well, obviously it has to end by 12/31 because they have to be in on 1/1. When should something get escalated? Meaning it's just not happening. You have a director that's so busy they haven't looked at it yet, and it is now the 25th of December, and they're uncovering for Christmas, and you don't have any other charges in. And where do I need to make the changes? So this is just a list of key stakeholders. It's CDM, revenue integrity, finance, revenue cycle leaders, reimbursement, managed care, clinical, internal audit, just a list. You may have some, you may have all, or you may have very few of these. It's really quite dependent upon you. First thing you have to do is state, what is the objective? So I start the objective being the goal. What exactly am I looking to accomplish? What does this thing look like in the end? And that's a deliverable. So on 12/31, I expect to have X, and that's a deliverable. So you identify the needs, define the actions to get there, assign your task, define escalation processes. And I always like to also, with the escalation process, I'd like to have a plan for every single task and action. If they were to say go maternity leave, and then who's going to do that? What's the backup? If somebody's been ill or unwell, what's the backup? Consider your project management group, as they can create the project plan and they can implement it quarterly so that you stay on track. With the PMO or project management organization, you go ahead and you determine a timeline. So when do you kick this off? What did you use in prior years? Did you do it in prior years? Going to take long? You're going to try a process together for this? What does this look like? What are those milestone dates that you cannot move? So code releases, you can't move them. Holidays, those don't get moved. Non-negotiable, like the 1st of January. These actual dates, the project plan, as non-movable milestones, you have to plan around them. When is the completion date? And if you say 12/31 and there's any hiccups at all, you're not going to make it time. And most people like to have everything in on or before they start occurring. So the 23rd of December is the 20th of December. That's when most people shoot for. We understand that PICS codes tend to come out late, like the 10th of December. But if it does 20th of December, that allows you to have a reasonable holiday instead of trying to redo your CDM over the holiday break. Define when issues can be escalated. So say it is the 20th of December, 9 of your clinical departments haven't responded. That's an escalation, but truly it should have been escalated months before. So you have to define what is the escalation trigger and how will you escalate it. So the where.
Hey, Bill.
Where is the data that can be made right up? Yeah.
Hey, Bill, you're breaking up quite a bit, I think, for some people right now. I'm wondering, maybe turn your video off to start. Let's see if that saves some bandwidth for us. And then we'll keep going, but people can catch what you're saying.
Stop the video. Is that better? Dusty,
We'll
is that better?
Sounds better right now. We'll give it a try. Thanks.
So people, do I need to go back at all, Dusty?
You might want to go back one slide.
Guess not. One slide. So let's timeline. The timeline is based upon when you want to get things. So if you decide it's the 20th of December to give yourself time for the holiday break, and the timeline ends non-movable on the 20th. That's the end of it. You can't move it. You have to backdate other things like code releases, holidays, non-negotiable days. Those have to go in the timeline as well as non-movable. So basically you're setting up concrete barricades on certain portions of the timeline. Then you define when an escalation is. So if something was handed out to a clinical department and more than 7 days elapse, escalate to the next person to make sure it gets done. So the escalation is defined by you in a procedure so that everybody knows what's going to cause it. Then where are you going to get the data? Will the changes be made? Most people, they can use their software, or many people still use Excel and send out Excel spreadsheets for just that department. Where's the documentation going to be stored? And as I spoke earlier about folders that you create. So that's kind of on your intranet. Put it on a folder. PHI goes into that folder if it's accessible by people who do not have the right to see that information. Where will the workflow become standardized in the future? So we've kind of set up the prep work. Now we're going to set up the framework. And the first thing we do is start with those policies and procedures that I spoke about. Organize all the necessary guidance for a kickoff meeting: templates, instructions, project plans, policy for maintenance. Do a kickoff call with the policy and procedure. Make sure you identify the timelines and resources required. Ensure the data is available. So for example, don't schedule that the data is due on November the 1st for HCPCS, but the HCPCS doesn't come out until December. Make sure it's going to be there and in your project plan. And then this kickoff is very important. A lot of people say, oh, it's just another meeting. It basically benchmarks where you want to be, what the roles are, what the expectations are, and what is going to be that escalator if it doesn't happen. Set up a specific email address. We usually did, like, one that I used in another place was chargemaster@xyz.org. That's a specific email that anybody could communicate to the Chargemaster team about questions, and it was always in one repository. VitalWare does have a suggested maintenance schedule, and this is where it's in the software. And there's yearly, monthly, and quarterly. So when I make a framework, I like to have something like this. So yearly, I want to do a pricing analysis. I want to do the limited data set peer data analysis. I want to make sure all the codes are up. Monthly, get rid of any deleted NDCs, description reviews, pricing analysis, Medicare code changes, APC changes, invalid modifiers, duplicate CPTs. Quarterly, the deleted codes, the new codes, the missing primary add-on codes, the NCCI, the non-billable recognized by Medicare, E's and M's. So there are a maintenance schedule you can start with. One of the things that also I like to do in the yearly is I like to do a volume review. We'll talk about that in a minute, but if you have zero volume, there's usually a reason that you can get it out of the Chargemaster or find out why it's still there. You organize all your data first. So create CDM reports that are specific to the organization. Use a prospective analysis. Our solution offers a 1-1. If not, if you don't have VitalWare, then go ahead and use Addendum B from the OPPS guidelines. Addendum B will show you what's new and what's changing. There are also a few other addendums under 2021 that will show you the different Medicare changes. Make sure that you're also looking for any specific payer codes that are not part of CPT or HCPCS. Maybe they're level 3 codes like the S codes in Blue Cross. Make sure they're there. Do a dashboard and provide a view of the number of lines being affected by future changes. Run the analysis reports early and frequently so you see where you're at. You have to have a running analysis. Organize the full CDM data. It should be based on your ongoing maintenance. It should be simple and look for any lingering deleted or inactive codes. Get rid of them. If they're deleted CPT codes and they don't have a replacement, then they shouldn't be in your Chargemaster after the date of deletion. They should be inactivated, and inactive CPT codes, same thing, inactivate them. Remediate these prior to even starting your year end. So basically in that prep work, do a bit of a cleanup. Then you run for the overall CDM for deleted codes. So this is just an example of our report. There are many out there, but basically you run your whole CDM up against next year's file and you say, which codes do I have in the CDM which are deleted, completely deleted? And we'll talk about inactivated and new in a minute, but right now, these are deleted codes. We want to get them dealt with first. So you're going to go through and identify. So here you see all these occupational therapy. So when you're working with med or OC therapy, you're going to want to, occupational therapy, you're going to want to go ahead and give them a list of all the codes that are going to be deleted and then work through, well, how do you order these? Make sure they understand these orders will change. Then the invalid CPT codes, you'll do that as well. And then finally, reports for deleted by department. We have a report, but there are others. You can use the revenue code or the CPT code, addendum B, for those that have been deleted. And you just go, write down the CPT list. Okay, 8,000 series is lab, 7,000 is radiology. You've got these different code ranges that you can use to look for the deleted. And then I start with the data acquisition. So I have now done the policy, the procedure, the prep work. I've cleaned it all up, and I'm going to start with the data acquisition. Before I start with data acquisition, there's another step in here that's part of the deleted code thing where I look for no volume codes, things that have not had any volume in a revenue and usage for 18 months. If it is after 18 months, it's outside the billing cycle, and it's likely never to be used again. And what happens is you clog up your CDM, you clog up your ordering system with things that really aren't applicable anymore. So it's best to inactivate them and ensure that the most refreshed version is for your upcoming year. So we spend a lot of time getting rid of those zero volumes. There's always a hesitancy that, oh, well, the surgeon might want it again or this or that. You can reactivate it and make sure that it's up to the latest and greatest. But if it's sitting there with old data and it continues to age, it really could become problematic if it's ordered. I get the CPT code updates and I've done my analysis. So here's an example of a Prospective report, and you can do this with addendum B too. And it goes through the CDM and it says for 2021, as of 1/1/2021, I have 2 invalid CPT codes, 1 deleted, but it has a replacement code that I have to take care of, 11 deleted. And this type of analysis can be run as soon as the codes come out. So granted, they come out usually it used to be at the AMA convention, like the 14th of November, but it's early on. It could be October now, September, October, when the codes come out. So you're going to want to start running these reports early and start dealing with them early so that you don't come up to the end. You start with an overview of the changes. How many are added, how many are deleted, so you know where to spend your time for the departments. Okay, in this case, I've got 11 surgery codes, but I have 34 added codes in pathology, so I'm going to have a bit of a discussion with them about those. So you kind of plan out your timeline with what's going to change. I then, of course, talked about the deleted codes and what their replacements are. Software generally has this. Addendum B does not have this, what it's going to be replaced to. So you'll have the CPT code that was in 2020, and then they're going to be deleted, but here's potential replacement codes that you have to consider. And if there's no replacement code, then it's just not applicable. We also then add for new codes. So these are services that you have to work with the department to see, do you think you'll ever perform this? Do you have the equipment to perform this? So, you know, you've got new labs like flecainide and salicylic and amiodarone. You've got those new ones. So are you planning on doing those drug levels? Maybe you have a cardiac center where you use flec and amiodarone a lot. So you're going to start to look and say, do I do this? Talk to the ENT people about these nasopharyngoscopies, you know, and so start looking at the codes that are being added and talk to your departments with, do you think you're going to do this? If so, we need to put it in the system. Then the last step I do, so I've done the 0 volume, I've done my prep work, I've done my deleteds, I've done my inactivations and ads. Now I'm going to look at the very last thing, what changed? So I have my ads in, so I'm not going to miss charges. I have my deleteds out, so I can't charge the wrong thing. Now I'm going to look at what's being charged. And these are usually description changes. So I like to see what it was before and what did they change in the next year. A lot of times it's a comma. Sometimes it's just a strikeout of some words. But other times the definition so changes that it becomes much different or more harder to deal with. So for example, in 2020, we have the arthroscopy shoulder surgical debridement limited and extensive. And if you look in 2021, they've given you examples, articular capsule, articular side of the rotator cuff. They've gotten very specific, which may change your definition of limited and extent. So I do these changes last. Then finally, I organize all the department data. So when I go to talk to the department, I have already done their 0 volumes. I have a list of their deleteds. I have a list of their ads, and I have a list of what's going to be changed. I go and meet with them. And what I do is I just meet with them for pharmacy is at least 4 to 6 hours, laboratories 4 to 6 hours, occupational therapy an hour max, physical therapy an hour max. And I kind of look and see what are my bigger departments that I'm going to need to do. And I then do a job aid that says, okay, these are what's going to be added. And so that they can educate their staff on what those changes look like. And then step 4 is to make sure that what you're doing meets a project plan. And this is an example of a Gantt chart. There are plenty of different Gantt charts out there, but first and foremost, this ensures that nothing is ever missed. And that's the most important thing, because you can visually look at it, the tasks, the subtasks, to say, you know what, I forgot to do that. And you can see that it was never checked off. Or it's behind schedule. It also points escalation points at risk. So say something was due in the gray area, the very top one was due the 29th of 2018, but it's the red marker now, the gray is well overdue and we need to get on with it. The kickoff meeting is very specific. I usually hold the kickoff meeting as a general one at a high level of what the expectations are. I record that. I put it out so that a lot of people cannot make these meetings. It's there for the viewing. I put the MP4 or the tape on the internet for the kickoff. And those that can attend, great. But one of the things you want out of the kickoff is the last statement on this slide. Find out who's going to be your CDM associate. Who's going to be that point person in the department that you're going to communicate with, that you're going to make sure the questions are answered, make sure they're on schedule. So you have to have, as part of this Gantt chart and the assignment of roles, so if it's chemistry, who in the chemistry department is going to do it? If it's MRI, who's going to do that? If it's CT ultrasound, who's going to do that? Then we do the down and dirty department interviews. And for some departments that don't have a lot of changes, not a big deal. But as you saw, some of the departments have 34 additions and 28 deletions, and there's going to be a big change to that department. That's going to take a lot longer. Make sure that the CDM staff is articulate on the topic. I cannot tell you the number of times I've gone to CDM meetings where a CDM analyst has been part of it, but they really don't.
Hey, Bill, I lost you completely here. I can't hear you right now. Yep. Looks like other people as well. So
Hold on. I'm
there we
afraid
go.
if I do it, I'm going to lose you altogether.
I can hear you. You sound good now again.
Okay. Sorry, guys. Part of the problem is, in fact, my internet. While we're at it, Donna Terrell asked a question: when will HCPCS be loaded to perform the analysis? Current reports of CPT HCPCS are not yet out, and they're usually within a day. They're loaded up. So hopefully that answers your question. I would say I don't know, because it's been so messed up with elections and everything else, but it's usually around the end of November, around Thanksgiving, if not the 1st of December. HCPCS are always later. All right, so Dusty, I can't. So now we've done the department interviews, and this is where you have to sit down. You have to have people who are articulate in the topic. You need to define the goal of the interview. You know, what are we going to do today? Define your breaks. If you've got a department that's going to take 4 or 6 hours, define what those breaks are going to be. Do they have to answer emails? Is there lunch schedules they have to cover for? Define those breaks, kind of make up an agenda for the day. We start with the deleted codes, and you find out if there's a replacement, then the added codes, and finally the ordering module. You'll need somebody from IT there, or that runs the information system. So say radiology, you're doing the review and the interview, you're going to need somebody who manages radiology information systems there, because whatever code you add then has to be added and mapped to radiology information system and then back to the ordering module. So you're going to need to have them present. No usage charges, those 0 volumes. You know, I usually just bring a list in and say, I'd like to inactivate all these. There's no volume in 18 months. Do you have any concerns? And the usual answer is, I don't even know what this is. So shouldn't have a problem there. Revenue code reviews, if you need to get more specific on your revenue codes. And I don't focus on the pricing at all at this point. There's no reason to focus on that pricing at this point, because we're doing department level things. We just want to get the coding right. The pricing will come later through finance. So I don't usually have a lot of chats with the department on the pricing. I update the corresponding systems, and this is where the errors happen. If you're going to start changing the CDM, what is the ordering system that triggers it? Is there an intermediary module such as pharmacy, OR, lab, radiology, ER module? What's the physician ordering module like? Is it going to match? So you're going to have to start tracing it all the way through. So if I add a new item for XYZ, XYZ has to be in the radiology information system, and it has to be in the physician ordering system. And then you have to test it to make sure all those connection points actually trigger XYZ. I'll give you an example of what a catastrophe this one was. They did a CDM update at a small hospital in Texas way back in the day. I was called to do an audit because the government said there's no way they did that many angiograms. And what I found out is the CDM was correct. It was a chest x-ray 2 view. Radiology was correct. It's a chest x-ray 2 view. However, in the mapping between radiology and CDM, they didn't map it to the chest x-ray 2 view. They mapped it to a thoracic angiogram. So every time a chest x-ray was ordered it was performed, it was charging basically an aortogram. So this is the problem with the mapping. And if we go in and do compliance audit, this generally where we look. A lot of mapping issues happen. Make sure that the clinical systems are updated at the same time. So part of my checklist is if I'm for every one of my additions, I have add to CDM, add to, ordering module, add to, and I check those off with a done date and then a testing date that I tested it. So when I update the corresponding system map to the CDM, I start with a physician order. It has to be added to the dictionary, and sometimes that has to go through MedExec. Some of the ordering things are controlled by the chief medical officer's office. So sometimes that's the hangoff from the beginning, getting it into the ordering module. Then we have to map it, LIS for laboratory, then map the laboratory, the CDM. That's a big risk area because the lab tests are so specific. We find that several of the lab tests may link to one CDM or there's an explode code, parent and children. This is a big risk area. CDM must be tested. Make sure that you test it. You order something on a fake patient, you complete it on a fake patient, and you bill it on a fake patient. And does the bill show you what you expected to see, or does it not? And that's where I see a lot of CDM updates fail. They never look at the bill at the end. They just assume because it's right in all these places, it must be right, but the mapping could be wrong. Ultimately, you test these charges, and that's where audit, I usually get internal audit or revenue integrity or biller to say, okay, I put in for a 2-view chest x-ray, that's 72010, and do I have 72010 on the bill? Yes. Okay, moving on. So we do a very clear understanding of that. When I do the department deep dive, I'm going to do 2 of them. Here's lab, for example. This is, and I'm showing you this because this is a #1 risk area for CDM. It's very time consuming. You cannot leave it to last. So I like to make it first with the CPT codes. They don't have a lot of HCPCS codes involved. They can, especially with those drug screens, but they don't have as many as other departments. So I start with the added, the new, the deleted in this area. Because of the high volume, there may be multiple items for the same CPT code. You need to make sure that that's actually it. You have to confirm they still have the equipment able to do the test. So a lot of the equipment determines the methodology. So if the test was run by an older piece of equipment and an even newer piece of equipment, and that test is specific to a methodology, does that new equipment do that test in that methodology, or do I need a new CPT code? It is going to involve in-house and out-of-house. So what I do is I get the LabCorp or whatever facsimile that you would use, their coding book, and say, what is new in your reference lab for 2021, and get that list as soon as they have it. Make sure that you have built in your reference tests for your CDM. A lot of times I see just one line send out, and that to me doesn't work as well because you can't reconcile it. Equipment, we talked about that, and then the mapping is very concerning there. The laboratory sections, you will have to have different interviews. You're going to need one for chemistry, molecular path, immunology, blood bank, micro, cyto, and surgical path, because they involve different stakeholders. And if you ask the chemistry people what they're doing at surgical path, while they are certified laboratory people and they have a license, they may not know that specialty like the surgical path people do. So here's an example. The path in this case had 32 added, 1 deleted, 8 revised. So I make this report for them, identify what it is. I look at the 34 adds and I say, are you planning on doing that?
Hey, Bill, we lost you again. See if we can get him back here. I don't know if it's your headset or what, but you have no audio. You can still see your screen. I know y'all don't want me to be running through this presentation for Bill. So we'll give it a little bit here. Appreciate you all kind of fighting through these technical difficulties today with us. All right, I'm guessing he is logging out and logging back in. Let's hold on for a minute. I appreciate you all doing that. I'll make sure we can get through the content with you. Just a reminder that if you do have any questions about the content or the presentation or anything we didn't even present but related to this topic, please submit those in the Q&A and Bill can get back on here. We'll do our best to go over those with you at the end of the presentation. Yeah, we get the recorded webinar in the presentation will be available following the presentation today. So if you go to our website, vitalware.com, and under resources, under the webinar section, we do post most of our webinars there available on demand that you can watch just through video, and you can download the slides there as well. So it looks like Bill is just getting back on here, so hopefully his audio works when he does finally appear, but we'll make sure you get those. And again,
Dusty, you back?
There, we can hear you. Perfect. Yep.
Yeah, we're sorry about that, guys. I think that the polls for everybody are taking a toll on everyone's computer systems today. Sharing again, and I apologize. And where did we leave off on the lab?
Yep.
Okay, so basically, we're going to start back at the lab, and I apologize for starting over. This is the #1 risk area for CDM. It becomes a problem when you're dealing with pain management and the ordering of pain tests and drug screens and what have you. There's molecular pathology, which is very, very complicated. Genetic testing, you have your send-outs, you have your pathology. So this requires a lot of attention, a lot of time, and you can't rush it. I start with the in and out of house tests. So I'm going to want to know, what are your referral tests? What are you sending out, and what do you have that you're doing internally? I start with the internal tests, and then I build the referral tests. I usually am a bit taken back if I see one line that just says send out, because there's no way to reconcile that. So I like to have, if there is a litany of tests that you're performing more than 20 times a year, go ahead and make that as a send out test. And make sure that the methodology they use in the CPT code that they provide you is in fact consistent with the CPT book, and add it, because ultimately you'll be the one charging it. And if they've coded it wrong, that's going to be on you. The next thing I do is the equipment mapping. This I spend a lot of time in. Generally, if I'm using lab information system, I get a report out of lab information system showing me the actual lab test and then a print number or however it connects to the CDM number. And I make sure that that report, that mapping report, is part of my documents for that department. And then we go through it and we say, okay, this lab test in your radiology information system, is this CPT code? Is that correct? Yes or no? And so that takes a bit of work. So the next thing I do is I look at my laboratory section, and you cannot expect chemistry to understand everything that cytopathology does, or blood bank, or surge path. So use the people within that, because there are different clinical stakeholders. And I start off with those changes summary. You know, we know that path and lab are going to take a while. There are 34 added. 1 deleted and 8 revised. So that's going to take a while, 34 new codes. So what are those codes? And do those codes part of an explosion? And are we going to have compliance review it? And how do we set it up in the physician ordering system? So these are not inconsequential time periods. So when I look at those 34, what do I have? Well, I have a bunch of chemistries. I've got the acetaminophen, amiodarone, flecainide, methotrexate. So I've got a lot of chemistries. Then I've got some translocation analysis for tumors. So I've got some molecular stuff going on there, the tumor proteins as well. So we're going to have to separate these laboratory additions into what I call lab centers of excellence, meaning don't give the chemistry drug test to the molecular people. Just some more examples. We have oncology, thyroid, mRNAs. So we also have to look and see, are any of these sendouts? You know, do I not even do it here? So this epilepsy genomic sequence analysis panel, very few people do that. That goes to a specialty lab. So what is 81419? Who's going to do that? How is it going to trigger? Is it going to trigger when you go ahead when you order the test? Or is it going to be on completion? Because the charge may not come out for 3 weeks or a month. Because it was when you get the result back. And so then you've already got a bill that went out the door. So you have to look at these things. I look at the deletions, you know, we have 1 deletion, and then I'd have to look at the replacement codes and go through them with the department, say, this was deleted, but do you do one of these? Then the revisions are in red, and I just go through very quickly with those revisions in red. And this says now this is a total, where in the past it didn't say total. So does that make a substantive difference to you? If I go to radiology, kind of the same process. I have 1 ads for CT and 1 for radiation oncology, so I'll speak to them. And then deletion 1 ultrasound, 1 nuclear medicine, you know, that's going away. So here's one, the ultrasound follow-up study, that's been removed. There is no replacement code. So what are you going to use instead? Is it limited or what is it? Radiology revised codes, these again are the descriptions, and it may change it. So for example, here's a CT of the thorax, it's diagnostic. So it's not to be confused with a CT, screening CT for, you know, aneurysm. The pricing is the very last step. And what you need to do is look at your revenue impact. So if I look what it was in 2020 and what it's going to be with the changes in 2021, that gives me a flavor for the revenue impact. And I start with Medicare. You know, here's what the codes were. This is what the new reimbursement rate is for that code. And if your most performed CPT code is one of those they deleted without an alternative, that's a big hit. You're going to have to work with that. Deletions that, you know, again, get them out of there if they've been more than 18 months. And then review all pricing and an annual maintenance review. So I pull in the cost report people for pricing. I bring in managed care because I may have some carve-outs that I have to price according to certain metrics. Maybe my CDM contract says I can't escalate my prices more than 4% every year. And what does that look like? So strategic pricing is last, and it's then we also do a peer pricing analysis out of our software. We can look at multiple different hospitals depending on size, location, competitive nature, and say, okay, this is what they're charging, and then get a sign off. And finally, we've done all of this. We've done the prep work. We've done the project plan. We've done all the different adds, deletes, and changes. We put it all in place, and we have to audit it. So we set the standard, which is that new CDM. Then I measure against it. All those adds, changes, what are those? I have to be able to go ahead and make sure that they fire correctly. And if they didn't, then that's not going to meet the standard. Compare the results and make any changes and then re-audit it. So this is the audit cycle that we use for almost everything in rev cycle and finance. And so the result here would be the same. You just have to make sure you have the right standard. So our standards we'll be using are CPT and HCPCS codes changes. We're going to measure those against what we have. So did we forget one? Did we add two of the same thing? Look at that and show errors for investigation, and then we go and change the practice and re-implement it. So that was very jagged, and I lost you a couple of times. We're pretty much at the end, so I want to answer those questions or go back and review any of those areas where we fell off. So in summary, maintenance requires rigorous activity. This is not just something you can slap together. A work plan has to be created. So if you have 2 CDM analysts for 2,900 beds, at 17 different locations, not going to work. How are you going to extrapolate your skills out to the whole? Created an internal landing site with job aids, policies, procedures, project maps, calendars, and then check the mapping at the end. And I keep harping on that mapping, but that's the #1 reason that CDMs go awry and charges go awry. So at this point, Dusty, do we have Q&A? I know I've made a bit of a mess with the internet. What are we meant to do about this?
Yeah, no, if anybody has any specific questions about things they might have missed through the technology issues we had today, please put those in Q&A now. We'll try to re-review those. We just have one question to answer right now. We do get some questions around if it's going to be available, but yes, you will be able to rewatch this as well as download the presentation at the webinar link where you signed up as well. So same spot, it will be there. We'll send out an email of where to find that. You also get your CEU information in that email following the webinar here. But Bill, we only have that one question right now, but please, if others have more, put them in that Q&A panel.
And I do apologize for this. I mean, the internet's been sketchy all day, so I apologize for that.
Well, you can't control the internet. No worries, Bill. So when do you look at insurance-specific yearly changes? For example, the 2021 UHC lab test change that goes into effect as of right now.
What was that, Dusty?
When do you look at insurance-specific yearly changes? For example,
insurance-specific changes. As soon as I have that contract data, the insurance company pulled those payer guidelines down with all their changes, and I make sure as part of this, as soon as those CPT codes come out, I look at what the insurance actually states. And make sure it's it, because a lot of times the send out tests will be affected. They need prior authorization or something like that. So when I'm doing CDM analysis, part of the review I look at is prior auth for some of my more expensive tests and procedures. So I start as soon as I can.
Great. Looks like they like that answer. Appreciate it. I don't have any more questions right now, but we will wait a minute.
Oh, this was, it says IE 2020 that goes into effect as of right now. If 4/1/20. Aaron, I'm not particularly sure. Are you suggesting that UHC Lab put a 2021 code in on 4/1? It would have been one of those that was adopted by the AMA. It would have an effective date, so it would have been adopted in 20 or 19 or 20 or 21, one of those 3 years. It would have been adopted. It would have come out in the quarterly CPT code updates by the AMA, because they would show you the effective date. So the change won't be seen until the book comes out in November, but in fact it was active 4/1. So I would do it as soon as you know an active date, and that usually when they get a code approved, it'll say, you know, provisional acceptance or whatever, and the CPT code changes in the quarterly edition, and it will tell you when it becomes active. And the instant I wouldn't wait till the end of the year. I mean, definitely do it.
Well, it looks like they corrected it though. It looks like they corrected it though. It was supposed to be 4/1/21, so it is next year.
Oh, okay. Well, then you put it in for 2021 with a future date.
One more question came in. Can you speak more about pharmacy and how to address the issue of modifiers needed for 340B drugs? Well,
one, that's a bit of a sticky wicket. you've got a couple different modifiers in pharmacy, but for the 340B, those that are required, especially for Medicaid, you are going to need a list of those 340B drugs that in fact have a discount by the Medicaid system in your state that you're doing. You're going to have to put the modifier on that if in fact those drugs are in your virtual formulary. Now, one of the things that I use is I don't use the HCPCS code for this. I use the NDC number. And is that NDC number one of your replenishment drugs that you're putting into a virtual outpatient, that on those drugs you need to put those modifiers? So follow the Medicaid guidelines. It's usually about the Medicaid discounts that we're talking about, and make sure that you have the NDC numbers are right. Usually the modifiers are incorrect because incorrectly applied because the NDC number is not the number on the package or the vial. It's the NDC number they put in the Chargemaster that might not have changed for a long time. So you have to get the one that's going to be delivered to the patient and put the modifier on that. So that one's, when I said a stick of wicket, there's a 4-hour pharmacy chat we could do about that. If you got further questions, then just write us and we'll try to work with you.
Perfect. That is the last question we have today. I did put the link in the chat. If you are curious of where to just keep track of our current upcoming webinars, as well as all the past ones where you can rewatch them or download the slides, that's where you do it. There's also a place to sign up for an email list where you get emailed all the updates on when webinars are coming and things like that there. So you can sign up over there or sign up for our mid newsletter at the bottom of any page, and we'll make sure to update you on the different content and resources we're delivering to all of you. Other than that, looks like we have no more questions. We really appreciate you sticking with us and fighting through some of those technology issues we had. We do have a great webinar series coming up for the rest of the year that hopefully gets you prepared for all the year-end changes and updates, as well as a pharmacy charge capture webinar. So a lot of great content coming up. So make sure to check out that webinar page and register for those so you don't miss them. Thanks to everybody. Appreciate it.
We'll try to get internet that works, yeah?
Internet helps.
I think it's the polls. I think they're all trying to calculate who won.
Yeah, they're submitting those through the Wayback Machines and seeing if they can take them out today.
So I apologize, guys. So sorry. I've never done a fragmented one like this.
It fit my brain well, so I appreciate it. All right, thanks everybody. We'll talk to you soon.
Thank you. Bye-bye.